Welcome to the days of
Daddy, scribble my name. Just scribble it.
Okay, just scribble it.
I'll ever do that. I don't know who I am. Read it in the mirror.
You could have left. Oh yeah, we're going to.
Hi Mom, send mine.
Oh, that was the thing on this side. Who won it? Who won the Bible?
I don't know.
So I need everybody that's on the other side of Miss Nicole over here.
Oh, you took this way.
Yes, that's you, Michaela. That's you, Denise. This way. This way. Here. I need you to meet the guard over there. Come on, Darnell. This way, everybody go the way. That way, that way, that way, that way, that way, that way, that way. They're acting like they can't see me. Or can't hear me either. I know it's very loud, isn't it? Is this very, very loud? Can you turn that down a little bit? I think so. Oh, you think Joyce is going to bring it? If she teaches it? Here, how do we turn this down? Everybody over here. Look, the quicker you guys move this way, the quicker we get this over. Alright, move them.
Scribble my name in there.
I need to sign it.
Need a pen?
Yeah.
There you go. We'll give you a pen as long as you leave it here so we can sign it.
Okay. All right. As of November 27th, so 3 years ago, the federal government decided that they would put new regulations into place. So there was a new set of regulations that are put into place every year for the past 3 years. This November 27th is the last time we get a new set of regulations. Thank goodness. However, part of this new regulation is trauma-informed care. So trauma-informed care means that our new admissions, and we'll be going over it with Miss Laura here so she can decide how we best way to do this, whether we want a different assessment for trauma-informed care. We have a set of questions, very few questions, that we need to ask our new admissions to see if they are in fact PTSD, if they've been in a car accident. We get a lot of Ocala trauma patients in car accidents. If they've been affected long-term, everybody reacts differently to different things. Some people get traumatized by a fall and a fractured hip and a loss of function. Some people are traumatized by a CVA. Open hearts, they say, is very traumatic for people, that overwhelmingly, like 80% of open hearts get depression after the open heart surgery, and it can linger months and months. So they want to make sure that these folks get the proper mental health services that they need in order to deal with these kinds of issues. So our new admissions we'll be watching for trauma informed care. We will also, and what happens is if we do identify as a therapist, if a patient tells you that, they get teary when they're talking about it, or they just, when they're talking about whatever occurred to them, their loss, that there's been an issue that, then we refer them to Dr. Dash, to our psychiatrist and our psychologist, Dr. Michelle Carr. They both can help to address that. So we want to make sure that we capture it, even if we don't capture it on admission, because sometimes they admit and they'll say one thing, but then when they settle down, because things are kind of harried, and then they decide, later they start talking, they have a conversation with really anybody, with any of the CNAs, with any of the nurses, with the housekeepers, a chef coming in, take their order, and then all of a sudden they start crying about their accident. Well, we know that maybe we should give them some more help. So I don't think it's a bad idea. This is Dr. Dash, and he's going to give our in-service today. You guys have seen him around, I'm sure.
Hello everyone, welcome to this presentation. This is about the trauma-informed treatment and PTSD. So let me start my presentation. I hope you can see every thing on the slide. So we're going to focus on PTSD and trauma-informed care in LTC. I'm Dr. Pari Deshmukh. I'm triple board certified psychiatrist, certified in the board of general psychiatry, addiction medicine, and integrative holistic medicine. I'm also a certified psychotherapist in psychoanalytic psychotherapy, cognitive behavioral therapy, as well as interpersonal therapy, and my expertise are in geriatric psychiatry, in long-term care, where I have been working for many years on a daily basis. And so I would like to focus my presentation for LTC caregiver population, as well as patients and families. So today's learning objectives are to learn what trauma means, and to learn what PTSD means, and then to learn the consequences that trauma and PTSD cause, and how to provide a trauma-informed care and manage PTSD in LTC setting. Now there is a new rule called trauma-informed treatment, where we have to recognize the trauma and provide the care accordingly, and this presentation will help with that. So first of all, we need to learn what is trauma. Basically, trauma is experiencing physical or psychological traumatic event or events, and they could be of many. So let's see what are the types of trauma that human beings can experience, and there are a lot more than we may have thought. So first of all, physical abuse. If child is grown in family where parents are abusive, where parents are alcoholic, had personality disorder, had psychiatric disorders, substance use, that leads to a lot of physical, emotional, verbal abuse to child. But the abuse need not to be restricted to childhood only. It can extend into adulthood and even in geriatrics. Anyone can be victimized by physical abuse. So that's physical abuse, a trauma. Verbal abuse is also a trauma, because we may not think verbal abuse to be a big trauma, but a child or any victim is different for them, and their meaning and interpretation and the impact of even the verbal abuse could be tremendous. Emotional abuse, again, it need not to be only through verbal ways. If somebody stops talking to someone, that can be emotional abuse. So there are various levels of emotional abuse at what they experience in variety of relationships, whether it's in parenting, whether it's the school, whether it is the adult relationships, or the relationships in senior age, doesn't matter. The abuse can extend any time. It's just that in children, the abuse has a lot more impact than if it happens in adults. Because in children, the brain is developing and a small trigger can lead to big impact. Sexual abuse, huge. Molestation, inappropriate touching, rape, a lot of sexual abuse. There are a lot of types of sexual abuse, and again, the impact is tremendous. Losses, losing loved ones, abrupt loss, lack of proper grieving is a trauma. Abandonments, not only by parents, but by any relationships, rejections, physical pain. We may not even realize that severe physical pain can be a traumatic experience for someone. One thing is bullying that I did not include here. It can be a trauma in school. Near-death experiences can be a trauma. Motor vehicle accident, obviously it's a traumatic event. Our veterans going in combat, we hear about PTSD and trauma a lot with them because combat is a very traumatic event. Violence, even if it's not combat related violence, any type of violence, kidnapping, even if violence is not involved in kidnapping, it's a trauma. Starvation, homelessness can be a trauma. And more importantly, we may not even realize that a hospitalization can be traumatic for someone. Now, I have been hospitalized. It was not traumatic for me, but for someone it could be traumatic. And depending on what type of medical hospitalization they had, and what type of physical sickness they had, it could be traumatic. Even nursing home placement could be traumatic, which applies to us. Even sending patient to ALF could be traumatic. Baker acting patient and sending them to psychiatric hospital can be traumatic. So there are various ways of trauma, and one event could be traumatic for one person and may not be traumatic for other person. It all depends on their inner conditions, inner structure, how they perceive it, the experience as. So we should not interpret what trauma means. We should basically rely on patient what it means to them, what event caused what impact. We may just narrow our thinking and feel that combat and motor vehicle accident and violence is the only way of trauma, but no. Rejection can be a trauma. Hospitalization can be a trauma. And so we have to broaden our definition of trauma and really ask the patient, have you ever felt traumatized by anyone? And go from there and see if you get any answers. And it's a very broad way, but it's a better way of recognizing the trauma. No, trauma is a broad term. Again, we may think that trauma means a direct experience of trauma. That's just one way. But it could be witnessing the trauma. A child witnessing a motor vehicle accident may not be in the vehicle may not be in the accident, but saw accident in front of his or her eyes and be a traumatic. Learning about someone close being in trauma is also traumatic. So, let's say mother was kidnapped, and that's traumatic for a child. Or a child was kidnapped, very traumatic for mother. So learning about trauma to someone close, or even knowing that their father went to a combat could cause trauma. Repeated exposure to similar trauma, when the trauma occurs in similar related smaller trauma can be a re-experience of it. Extreme exposure to trauma details. So the trauma may not even reoccur, but just exposure to the details of the trauma, reminder of it can be traumatic. So trauma is a very broad term, and you can be either witness of it, then you can be a victim of it, or you're close to one to be victimized. After DSM-5 has broadened the definition. DSM-5 is the book that we use for diagnosing PTSD and trauma. It has broadened the definition of trauma knowing how much impact it has on our patient population. Now let's talk about PTSD. PTSD is post-traumatic stress disorder. It results from trauma when trauma is significant enough that it can lead to PTSD. But sometimes trauma doesn't lead to PTSD, but still has negative impact. So let's learn what PTSD is. PTSD has three main components. First of all, the patient re-experiences their trauma over and over again. They avoid any exposure to any trigger related to trauma, and they're hyper-aroused. Those are the three main features of PTSD. So let's learn our brain. As you can see, we have in the middle core brain, and we have cortex. I'm not sure if you can see my cursor, but the outer portion is the cortex, and the core portion is the core brain. That's where our limbic system is. Limbic system is made up of amygdala, hippocampus, thalamus, hypothalamus, cingulate gyrus. All these structures are there, which are core for our survival, for our existence. We have our fight and flight response there, fear, drive is there, aggression, drive of sex, drive of aggression, anger is there. These are all necessary for our survival, okay? And they are there. But when there is a traumatic experience that happens, the hippocampus is the area where it processes the memory, and then it stores it in other parts, and amygdala is where the emotions get predominantly stored. When the trauma happens for a child or anyone, the hippocampus doesn't process it properly, it just dumps everything quickly into the limbic system, which is amygdala and the other system, and then it remains dormant there, and now the trauma kind of fires like any small stimulus, and the patient does not have difficulty to impact their behavior, thinking, action, consequences. So that's the neurobiology of PTSD. Okay. So what does the experience of trauma mean? That means that patients have recurrent, intrusive, and involuntary memory. Again, recurrent, again and again, and they are not looking for it. It's intrusive, comes to them, and it's involuntary. They re-experience the trauma through their memory. Okay. The second is recurring distressing dreams. So memory is during the daytime, but at nighttime, the brain is trying to process the trauma by producing nightmares. So basically, memory is the reason we have this experience is because brain is trying to master the trauma, trying to process it, and that's his way of doing it. And it's just very uncomfortable and problematic for patients, but it is brain is just trying to heal itself by doing this. It causes dissociative experiences and flashbacks, and causes intense prolonged distress to any exposure similar to the trauma, or it can cause marked psychological reaction. So they are very sensitive now to anything that can remind them of the trauma. They can react, and that's also re-experiencing the re-experiencing trauma will be a small stimuli also now. Second portion is avoidance, because it's so painful to experience the trauma and to have these flashbacks. They would rather avoid the stimuli, anything that can remind them of the trauma, thoughts, external cues, anything that was associated with trauma, they may avoid it completely. So for example, rape happened at some place, they may never go to that city or that area of the city because of the possibility that it will remind them of those events. So avoidance of stimulus, some avoid watching TV, some avoid meeting some people who remind them of trauma. So avoidance of stimuli is the main thing. Inevitably remember the events. The brain has dumped everything so quickly they don't even remember the event properly, but the feelings are very active. Negative belief about the event have developed. Distorted cognition that the event cause and effect does not make sense, the details are distorted, because again, brain just dumped everything into the limbic system, and now it's there in the form of feelings, but not the details. So the negative emotional state, diminished interest, inadequate experience quality state, all these can be related to the avoidance of the traumatic cues. And hyperarousal, but they don't want this trauma to repeat again, so they're on guard all the time, that they're hyper vigilant that what is going on surrounding. They get exaggerated startle response when something triggers them. They can have irritable behavior because of this. And sometimes there's so much shame and guilt that subconsciously they have reckless self-destructive behavior, poor concentration because so much going on in the mind is always trying to process something. And because of all this, their sleep is disturbed. So that's hyperarousal. So what are the consequences of the trauma and PTSD? So first of all, trauma, it causes shame and guilt because I was traumatized and I am so weak and I am helpless. And these feelings come back and they can cause depression. They don't want to talk to other people, socially withdrawal. So depression is a very common consequence of PTSD. Similarly, the fact that I feel, actually patient is saying that I feel I'm weak, they can develop generalized anxiety and panic attacks, and then they develop maladaptive coping mechanism, such as eating disorder. They may resort to alcohol or substances to numb their feelings, or their body may process the feeling in the form of chronic pain or headache. So these just body are trying to process it, or they are trying to numb themselves by going to this maladaptive coping skills. Sometimes the trauma gets so deeply impactful that it can lead to psychosis, delusions, and hallucinations. That delusions is false belief, hallucinations, seeing, hearing things that are not there, aren't there. Sometimes depression gets so severe that you may even have suicidal thoughts and attempts, and some may even commit suicide. So this reaction can be inwardly directed in the form of depression, suicidal thought attempts, or it can be outwardly directed in the form of being easily irritable, agitated, aggressive, even violent. Again, they're reacting outside, and depressed patient react inside, or it can lead to maladaptive coping, such as eating disorder, alcohol, or the body can react in somatic symptoms. So those are all the negative consequences of trauma, and this figure nicely explains, as you can see in trauma. I'll start from the left, can lead to depression, irritability, loss of interest, numbing, insomnia, decreased concentration, restlessness, nightmares and flashbacks, intrusive memory, increased startle response, shame, self-hatred, panic attacks, emotionally overwhelmed, chronic pain, headache, eating disorder, substance use, self-destructive behavior, little or no memories, hypervigilance, dissociation. All these are negative consequences of trauma, and trauma can be even small but may have tremendous impact. So how to provide trauma-informed care? How to manage PTSD? First of all, we need to be educated. What trauma is, that I just educated you. It's a very broad term, and we have to be vigilant for it and looking for it. And we have to ask questions so we can recognize the trauma in its early stages, and then we can take actions accordingly. So recognition, awareness is very important. So continues, avoid re-traumatization. That's the main thing of trauma-informed treatment, that we should not re-traumatize our patient. Somebody was in violent relationship, we should not show them violent movies. We should speak softly to them, kind of doing everything we can to avoid the re-traumatization experience for the patient. And we should always be kind, compassionate. Listen to the patient, the really therapeutic. Human listening, giving a human ear to their emotions, and be really therapeutic. Share their feelings, empathize with them, and refer them to a specialist. We have psychotherapists in the building, we have psychiatrists and nurse practitioners in the building. We refer them because the treatments are available. Now, if they're very severely demented patient, we will not be able to do much psychotherapy work, so we can give medicines. But if patients are younger, they can process the feelings, we can do a lot with them. What can be done? Psychotherapy is the main treatment for those who can process the feelings. It can be done at individual level. It can be done at group level. And sometimes we have to admit patients to residential rehab, and it can be done at the rehab level. But treatment is available, and it is psychotherapy is tremendously effective. There are various types of psychotherapy. Cognitive psychotherapy, it works on how they see the trauma, how their feelings are, processing the feelings, working on their negative beliefs, replacing them with realistic positive beliefs, kind of rearranging the entire experience. Experience therapy is, again, what I was talking, is rearranging everything. So they expose themselves, not by re-traumatizing, but very gradual mentalization, processing, imagination, even virtual reality sometimes using softwares. But that's done very rarely. Most of it is the mentalization, imagination, remembering of the trauma. But in this time, it's a very safe environment. If you're not a licensed psychotherapy experiencing trauma, don't do exposure therapy to our patients. It's for psychotherapy that to do exposure with proper guidance, with therapists being next to them in a safe, secure environment. They process their feelings and now they feel better afterwards. So that's done by licensed therapists. EMDR is eye movement desensitization process. Through that, they do the various kinds of eye movement and do the reprocessing of the trauma. Again, similar to exposure, but associated with the eye movement. Again, stress coping is another way of therapy where they just teach them how to deal with the stress that associated is with the trauma. The other therapies could be present-day therapy, mindfulness, which teaches them how to be living in the present moment. It doesn't talk much about going in past and talking about trauma, but being in the moment and how to face the feelings. That is more present-day therapy, mindfulness. And medicines are really effective. The most common medicines are our SSRI, that is our selective serotonin reuptake inhibitors, Prozac, Zoloft, Lexapro, we can use them. Some of them are particularly approved for PTSD, some of them are not, but they have they have shown to be effective. So we can use the medication as per their tolerance level, as per their side effect profile, the cost of the medicine. Various factors come into play. We can choose the appropriate medicine to help patients significantly. And then we can help them with sleep. And if they have psychosis, we can help them with psychosis. A lot of medicines are available that are effective, but we will not know unless you refer us the patient, and you will not know unless you ask the right questions. So that's the main thing of this presentation, is to be aware how trauma can occur, what are the types of trauma, how it can impact their life, how to recognize it, what can we do about it. Okay, so what have we learned in this presentation? We learned what trauma means. We learned what PTSD means. We learned what are the consequences of trauma and PTSD, and how to provide trauma-informed care, that is trauma-informed treatment, and manage PTSD. Okay, I will be around in your facilities. Please to reach out to me if you have any questions. My nurse practitioner will be there. My psychologist are there. Please feel free to reach out to us. And if you need to learn more, please let me know the topics. I'll prepare the talk and distribute to all my facilities. Okay, thank you for listening.
So, any questions about it? Everybody sign the sign-in sheet, please. It is a mandatory in-service. Those that are here now don't have to take the test, but those that aren't here are going to have to watch the video and take the test.
Yeah.
All right. Yeah. There are some benefits to coming to TGIF.
Yeah.
we've all had friends or family. Yes, ma'am.
Insurance is covered, I mean, can we refer anybody?
You can refer everybody, yes. It's a new federal law. Yes, so the insurances have to cover. Which actually, that means your insurance also covers it if you have insurance. It might be traumatic, you know.